Welcome, everyone. Today we are here to talk about transforming public health data management from individual use to scalable workflows using R. I am Marian Anton, and with Carolina Mengoni Goyanons and Cecilia Palermo, we are from the Information and Health Statistics Office at the Ministry of Health of the city of Buenos Aires. Our office is composed of over 30 data analysts, scientists, and engineers. We are an interdisciplinary team organized into 3 sub-teams: data policy, data science, and data engineering. So what do we do? Well, we manage health data and statistical pipelines. Our users include the minister's office, other government departments, healthcare facility managers and professionals, researchers, and the general public. Our goals are to support health policy and management decisions, enable population health monitoring, inform clinical decision-making, and facilitate research. How do we do it? We design and maintain a data warehouse that integrates processed data from the city's health information system. As shown in this screenshot, the public healthcare centers generate data using the city's health information system called CIHEOS. We model this data and consolidate it into our internal data warehouse to develop data products. We have divided our evolution into 3 stages. The first stage, which we call the beginning, spans from 2019 to March 2020. We were a very different team back then. By 2019, electronic health records were implemented in our city's health information system, but something crucial was missing. There was no team to extract, model, and analyze that massive data for decision-making. That gap led to the creation of a small 10-person team as our first goal: to use this newly available data to support clinicians, health centers, and decision-makers with real, timely insights. Our early setup was modest but functional. We had an RStudio server, a server for code outputs, and a secure open source on-premises platform for file sharing called OnCloud, and an on-premises GitLab. As for our data sources and how we handle them, we modeled data from CIHEOS, the citywide health information system, using CSV files. So we created CSV files, one for each type of information from the electronic health records: a CSV file for consultations, another one for clinical notes, another one for health providers, pharmacies, and more, as illustrated in the screenshot below. The screenshot at the top depicts CIHEOS, its many modules, and its electronic health record module. As for the products we generated, well, we published Flex dashboards and reports in CSV and Excel, mostly summarizing activity across health centers. One of the first things we did for working with code was creating our own R library called Ahiser, which had useful functions for working with our data sources. Back then, pipelines and code executions were mostly manual, and projects were often solo efforts. Also, there was no formal management of coding environments, but that was mostly okay. The team was small and we could get by. As for onboarding to our code base, we relied on specific individuals per topic area around some loosely defined shifting conventions for data construct, but also there was no turnover. To make our journey more concrete, we are going to follow one thread through the presentation, which is our evolving work with the primary care division. Our first dashboards for the primary care division were simple but impactful. As shown in the screenshot, we use Flex dashboard to show data visualizations and metrics like number of patients and consultations per facility, or most common reasons for consultation. And these indicators were also distributed by CSV and Excel files, built manually and delivered periodically. Because our electronic health record system was problem-oriented, we could identify and share the top health issues presented in each center, insightful for both managers and clinicians. At this stage, the work was relatively static, updated occasionally, and focused on retrospective activity tracking. Then everything changed and led us to a new stage that we call emergency and rapid development from March 2020 to 2022. What pushed us to the next level? Well, the COVID pandemic arrived and our reality flipped overnight. We're in the city of Buenos Aires, that is a city with 3 million people that launched some massive efforts for testing, contact tracing, vaccination, all powered by public healthcare facilities. In this slide, there are 3 pictures depicting the massive testing and vaccination centers located all over the city and organized by the health ministry. Our statistics office was absolutely the main source of information for all of those strategies, so we needed to scale fast. Scaling fast meant, well, first abandoning slow updating CSVs and building a relational data warehouse. That meant creating new tables for the data warehouse representing consultations, providers, patients, physicians, clinical notes, etc. We started publishing dashboards and reports every week, every day, even every 3 hours on topics such as testing, vaccination, and the state of the city's resources. The screenshots in this slide show 4 dashboards with metrics and data visualizations, one for vaccinations, another one for the personal protective equipment supply status, and 2 for testing centers activity. Our role as the main suppliers of health data in the public sector during the pandemic meant that we had to move fast to build new pipelines and reports that supported new metrics and indicators for health monitoring, expenses recovery, and supporting decision-making at every level. That level of responsiveness had never existed in our team before. We had to generate weekly, daily, multiple daily reports. And that was only possible because we automated, streamlined it, and got very serious about our code and data infrastructure. We still did manual code runs at this stage, but we developed internal tools to automate pipelines using cron jobs and detect errors and send real-time alerts via email and Telegram. We had to handle very unstable data sources, which were constantly changing. And at first, manual execution was common to check that everything was running smoothly in a context of regular changes in our data sources. But as stability improved, we automated aggressively because serious stakeholders depended on the data getting through. We still didn't implement tools for managing our code's environment, but almost all projects were still solo projects. A novelty for us at this stage was dealing with team turnover, not a surprise in a high-pressure, unpredictable context. Onboarding became anarchic, heterogeneous, one-to-one as team members left and new people were hired to replace them. The need for better onboarding and documentation practices became evident. We moved from ad hoc handovers to project-based code organization, and we began investing in technical documentation. We adopted the DBO documentation framework that divides technical documentation in tutorials, how-to guides, explanations, and references. The image shows a 4-quadrant matrix that classifies types of technical documentation. Tutorials and how-to guides are at the top, focused on practical steps, and explanations and reference are at the bottom, focused on theory and information. The horizontal axis shows usefulness, dividing it into content for studying at the left and content for working at the right. And we made an effort to map our documentation assets and their dispersion in different platforms using this framework. This gave structure to our growing code base and helped us rethink where we stored our technical documentation and procedures, which frankly were all over the place: Slack, Google Drive, Microsoft Teams, GitLab, etc. Before COVID, our work with the primary care division focused on indicators like visits per facility or top reasons for consultations. After COVID, the challenge evolved to how do we re-engage patients who missed care during the pandemic. This required identifying at-risk populations, tracking current conditions, and, of course, building long-term scalable processes for that. All of this led to a first data mart with a socio-demographic registry of people in contact with the health system. That was the first table of the data mart. This data mart became the backbone for targeted re-engagement efforts. And well, by 2022, we had emerged on the other side of the tunnel. We were in a different stage that we can call maturity and consolidation. And the systems we had created in crisis weren't just the beginning. Now we had the chance to consolidate what worked, scale it up, and plan for the long term. Our team had also changed. On the internal drivers that pushed us to the next level, we can mention that we are now a fully remote team of 30 plus people with different onboarding stories. Some joined in person before COVID, others were hired during the pandemic, completely remote, and many joined after into a team that had already become complex and distributed. That led to differing work habits and collaboration styles, something we had to address. As for the external drivers that pushed us to the next level, well, as COVID-related urgency faded, new kinds of projects emerged. They weren't about crisis management, they were about long-term sanitary strategy. They require seasoned analysts, stronger infrastructure, and specialized skill sets to build data products and infrastructure for the future. So how is our data ecosystem today? Well, we now maintain a mature data warehouse and several data marts that are domain specific. As for our data products, well, they now come in any shape and size, and we have developed regular pipelines and processes for patient phenotyping, health monitoring and tracking, and health coverage analysis, among others. We now make a transversal use of Shiny apps and dashboarding, and we have also created solid data warehouse and data marts, creating and monitoring processes for the data engineering and the data science teams. For developing those data products, well, we still use manual code runs for ad hoc analysis, but we've run most of it through cron shops, and we finally created a cron shop data mart to monitor automated executions. As for the data processing pipelines, well, they became a big part of our job. So we developed the RTasker, a visual interface that shows pipeline execution flows via colored graphs. A graph represents the structure of a data pipeline. Each node corresponds to a script with a task, and the arrows between scripts indicate execution order and dependencies. The flow goes from top to bottom in this example, starting with Domingo, Sunday, the day the pipeline starts, and ending with fin, the end. And at the right side, you can see the execution history table, in which every row corresponds to each pipeline step and task from the graph, and each column represents execution dates. The dots indicate status for each task on a given day. However, we are also analyzing using the targets package for managing our data workflows. With 30 plus team members, we now have almost non-solo projects. So to manage collaborative coding environments more effectively in a large team, we started to use RM, which is a great tool for managing our packages in a project. Given our growth, onboarding to our code base became a priority. It was now a key issue, how we handled onboarding. So we created a Cuarto data science team internal website for our technical documentation. Also, we created a practical guide for onboarding new team members, soon to be updated in that internal website. Returning to our work for the primary care division, while new demands emerged around monitoring healthcare team activities and outcomes for healthcare service lines, such as checkups and immunization coverage. Those new needs led to more tables in our data mart and structured processes to model health conditions, care coverage, and healthcare team activity. So that's been a huge data mart growth. What lessons did we learn in all of these years, described in only a few slides? Well, the first one is that data engineers must be just as invested in outcomes of the data projects as the data scientists writing the code. Involve them early, make them be present in stakeholder meetings, and give them credit for the work they do to make our data products a reality. The second lesson is invest in interdisciplinary teams. We work with physicians, social scientists, academics, and industry professionals That diversity has been critical for dealing with challenges that in their origins can be technical, communicational, or of project management. And lastly, we couldn't have done any of this without free, transparent, open tools. They allowed us to respond quickly, be flexible and adaptable, and create high-impact data products in an environment where resources, priorities, and policies could shift at any moment. That's our story from a small data team with a handful of CSVs to a mature data ecosystem powering public health. We are very happy to take your questions. Please write to us at the email in this presentation, m.nanton@buenosaires.gov.ar. Thank you.